PH! Welcome to another episode of Curiosity Homes, where your curiosity is the limit. Here we bring learning over the internet, so please lend me your ears because I'll do the talking and you do the learning. At the end of this video, you will learn the distinction between the normal and abnormal breath sounds. I would suggest that you would use a headset in order to hear clearly the different breath sounds, but make sure you would adjust the volume of your devices into an appropriate level to prevent hearing damage. First of all, what are breath sounds? These are the sounds that come from the lungs during inhalation and exhalation that can be heard during auscultation. When an abnormality is heard in a patient's breath sounds, it could mean that other health issues may be present, such as asthma, COPD, foreign body obstruction, accumulation of fluid, heart failure, infection, inflammation of the airways, and pneumonia. These are just but the common examples of it. Although there are many reasons why we can hear an abnormal breath sounds. It is important for us nurses to develop skills in assessing the breath sounds of our patient for us to have a comprehensive health assessment techniques, especially in assessing the respiratory system. What is auscultation? Auscultation is a simple, non-invasive procedure that involves the use of stethoscope to listen to the sounds produced by the body. The stethoscope amplifies the sound that is produced in the lung fields. We use the diaphragm of the stethoscope to assess is either the anterior or the posterior part of the chest of our patients. How to perform auscultation? First, explain the procedure to the patient to establish trust and rapport. Second, stand close to the patient to gain access to the target area, in this case, the lungs. Third, if the diaphragm is cold, warm it by rubbing the surface to avoid startling the patients. Place the earpiece of the stethoscope in your ears and adjust into the angle needed for you to hear clearly the sounds of the lungs. Fifth, hold the diaphragm firmly against the patient's skin with enough pressure and have the patient take slow, deep breath through an open mouth. And 6. Listen to the sounds and try to identify their intensity, location, strength, pattern, and duration. Always listen to the patient anterior side first. Start at the apices and then move down to the lung bases. Then proceed to the same on the posterior side. Compare the right lung to the left lung. Also compare the anterior to the posterior side. Document the findings in the patient chart because in medical field could mean that whatever that is not documented is considered not done. There are types of breath sounds. We have normal, the vesicular, abnormal, the diminished breath sounds, and the bronchial breath sounds. We have the added or the adventitious sounds. We have the wheeze, crackles or crepitation, pleural rub, and stridor. Vesicular breath sounds. This is the normal sound on most of the lung fields. It is soft, low pitch, inspiration longer than expiration, no gap between the phases. So as you can see in the illustration, inspiration phase is greater than the expiration phase. And now, try to listen the vesicular breath sound. Bronchial breath sounds. Abnormal in majority of the lungs is far from the main airways. Loud and tubular quality, high pitch, inspiratory and expiratory phases are equal. Definite gap between both phases are noted. Heard in patient with consolidation, lobar collapse with patient bronchus, and lung cavity. If associated with consolidation, you may be able to elicit the following maneuvers: increased tactile firmitus, bronchophony example B, heard as bay, and then whispering pictorial quay. As you can see, inspiratory phase and expiratory phase are equal with definite gap in between. And now, let's try to listen the bronchial breath sounds. You could also assess bronchial breath sounds normally in the posterior, the superior part of the manubrium. So when you place the diaphragm, the stethoscope in this area of your neck, you could normally hear the bronchial breath sound. Inhale, exhale. And then here you could appreciate the bronchial breath sound. It is normal to hear in this area because it is normally be assessed in the tracheal area, but it is abnormal if you could assess that bronchial breath sounds over the lung fields, because the normal sounds that we could assess in that lung fields are the vesicular lung sounds or breath sounds. Now let's try to learn the adventitious breath sounds. Wheeze, continuous and musical quality. Usually assessed during expiratory phase, indicates narrowing of airways either due to bronchospasm or secretion in small airways. Low pitch or high pitch, either polyphonic or monophonic. High pitch or sibilant wheeze are usually whistling quality wheeze heard due to a smaller airways narrowing in bronchospasm, like in asthma. Low pitch or sonorous wheeze, also called as bronchi, heard when smaller airways narrow due to secretion, example in chronic bronchitis. High pitch wheeze is usually polyphonic due to variable degree of bronchospasm like in asthma, and is more common from we heard in daily practice. Monophonic wheeze is heard if there is obstructing pathology in the localized area. Now let's try to hear a wheezing sound. Crackles, crepitations. Interrupted, non-musical quality. It is usually assessed during inspiratory phase. Peripheral airways collapse on expiration due to either to interstitial fibrosis or secretion and fluid. During inspiration, rapid air entry abruptly opens this collapsed smaller airways and alveoli, producing a crackle noise. Crackles, crepitation can be early inspiratory in small airways disease like bronchiolitis, mild inspiratory in pulmonary edema, late inspiratory in disease like pulmonary fibrosis, pulmonary edema, COPD, resolving pneumonia, lung abscess, and tuberculosis lung cavities, biphasic in bronchoectasis. There are two types of crackles. It's either fine or coarse quality. Fine crepitations heard in bronchiolitis, pulmonary edema, and pulmonary fibrosis, while coarse crepitation is commonly be assessed in patients with COPD, resolving pneumonia, lung abscess, tuberculosis lung cavities, or bronchiectasis. friction rub. Pleural rub is commonly caused by an inflammation of either the visceral and parietal pleura. Low-pitched, grating sound similar to the sound of walking on snow, caused in consolidation, pulmonary infarction, uremia, and the like. Heard during inspiration when visceral and parietal pleura slides over each other. To differentiate between the rub, if it is being caused by the pleural lining or the pericardium, you must perform a brief inspiratory hold maneuver. If the rub continues during the maneuver, it is most likely a pericardial rub is the cause of that sound. Now let's hear the friction rub sound and other adventitious breath sounds. Now let's check what you have learned. So please listen to the breath sounds that I'm going to play and then identify what sound it could be. Yes, you're right. How about this? You got it. Now you're learning. There is only one way to master on assessment, especially in auscultation, is that you keep on doing practice every now and then. Keep on listening on the normal breath sound as compared to those abnormal breath sounds and the adventitious breath sounds. Once again, this is Curiosity Homes. Your curiosity is the limit.